Hello and welcome to this session of the Center for Podiatric Education. In this session, I'd like to continue the theme of several prior presentations, and that's a discussion of care of the geriatric patient by the podiatric physician and whether or not special training and considerations are necessary. We know that we have increasing healthcare burden by the geriatric patient, and I suspect that our training in the area of geriatric medicine is not particularly in-depth or adequate for the needs that are presently here and future needs. I was a student at the Pennsylvania College of Podiatry from 1969 to 1973. During those years, we had a professor of community medicine, a former APMA president, one of the individuals who developed one of the first residency programs in the United States for podiatric physicians. I believe it was at Giffray Medical Center in Philadelphia, a man who was both nationally and internationally recognized, Arthur Helfand. And podiatry in the late 60s and early 70s was making a transition in its educational program, and there was a suggestion that podiatrists would be more and more involved in the operating room and with advanced pathology. And this fellow, Arthur Helfand, ran a course in community health, and he would tell us back in the early 70s that the future of podiatry was going to be geriatric medicine, and it was going to be diabetes. I thought the guy was crazy. I used to think to myself, what does he know? Well, here we are in 2018 as I'm recording this discussion, and it turns out he was absolutely correct. If you think about the population that visits the average podiatric physician for care, a good percentage of those patients, if not the majority, are frequently patients who are either geriatric patients or are patients with diabetes. A tribute and a tip of the hat indeed to Arthur Helfand. He was correct. We know that the population in the United States, as in much of this world, is trending toward the elderly. And we are seeing, with increasing years, increasing percentage of our population. There are definitions from the National Institute of Aging. We know that we have three classifications of the geriatric patient. There's the young old, age 65 to 75. There's the old patient, age 76 to 85, and then the oldest old, greater than the age of 85. Again, if we look at percentages, by the time we hit the year 2050, we will be approaching 23 to 24% of the population being classified as at least old or young old, and therefore the need to address the podiatric concerns of this population. With aging comes increased disease burden, and many of these problems, such as arthritis and diabetes, are going to directly impact our practices with patients presenting with lower extremity manifestations of these diseases. We know that with aging, we have increased incidence of diabetes, and again, this is already reflected in the offices of many of our practitioners. We know that with aging comes increased incidence of peripheral arterial disease, and therefore our need to screen and evaluate patients for peripheral arterial disease, the need to recognize peripheral arterial disease, and to either treat patients for their lower extremity manifestations of peripheral arterial disease or make appropriate referrals for the evaluation and treatment of peripheral arterial disease when necessary. Again, we also know that patients with peripheral arterial disease have a higher risk of other comorbid conditions, particularly other cardiovascular issues. With aging comes an increased incidence and a risk of skin cancers. And here again, it's important that we look at patients for the possibility of common and uncommon skin cancers, and when necessary or when indicated, proceed with biopsy of lesions for the evaluation for potential skin cancers. We have common problems that are seen with increased frequency in the elderly patient, including onychomycosis. While this affects about 12 to 15% of the population overall, over 50% of geriatric patients have manifestations of onychomycosis. And if we look at patients who actually present to the Office of Healthcare Providers asking about nail pathology, a substantial portion of these patients have indeed onychomycosis, with Trichophyton rubrum being the most common infecting organism. We also have to think about treatment of musculoskeletal disorders in the elderly patient. The fact that they have increased incidence of arthritis and, in fact, a variety of other musculoskeletal disorders. The elderly suffer from sarcopenia with increased risk of disability and falls, unstable gait patterns that need to be evaluated. They have increased risk of osteoporosis and osteopenia with stress fractures and avulsion fractures, deformities of the joints and arthritic changes in the joints. We have deterioration of the joint structures and themselves, including the cartilage and ligamentous structures with limited range of motion and osteoarthritis, and a decreased bone mass and decreased osteoblastic activity affecting bone healing from fractures, osteotomy, fusion procedures, and various musculoskeletal complaints. We also know that with aging comes an increased incidence of various neurologic disorders that affect the lower extremities. And here again, it is incumbent upon the podiatric physician to evaluate patients for these neurologic disorders and be familiar with the recognition of these neurologic disorders if they first present with manifestations in the lower extremity, or conversely, given a patient with a diagnosed neurologic disorder, being familiar with the various treatment modalities available for them. So how bad is this problem? Well, it's bad enough that even the geriatricians themselves are starting to age quite a bit, as is our podiatric population. So what about the primary care podiatrist and the older patient? Well, we have to take the time to be familiar with the complications and sequelae of aging in our patients. For example, adjusting drug dosages and the fact that we have to be concerned with polypharmacy and decreased liver function and decreased renal function. We have to demonstrate increased familiarity with the diagnosis and treatment of disorders found with increased frequency in the elderly patient. When we're called upon for surgical interventions, we have to be familiar with the special needs in the perioperative time for the geriatric patient. At times, we will require modification of procedures, both the selection and technique utilized in the elderly patient. And then we have to familiarize ourselves and deal with the regulatory burden that goes with care of the elderly, particularly when it comes to Medicare and managed Medicare programs. So certainly there is more to the evaluation and management of the geriatric patient than simply caring for toenails. Some of the major problems that we are confronted with that require additional analysis and thought are the facts that many times in the elderly patient we get atypical presentation of disorders such as peripheral arterial disease. We have the fact that the elderly are at increased risk due to frailty, so that applying a cast or utilizing a fracture boot or a wrapping, issues such as that, dressing changes become more worrisome in terms of potential injury to the patient. Dealing with medications, we have to take more time, look at the medications the patient is taking, worry about drug interactions, worry about physiologic decline in those patients. We have to worry about cognitive disorders, and can the patient comply with our requests? Does the patient have the ability to comply with our requests for care, for dressing changes and monitoring of wounds and so forth? And then we have issues of informed consent and dealing with problems in the elderly such as advanced directives. It's interesting that the elderly, because of their comorbid conditions, present the greatest challenges to us as clinicians, and yet frequently, although they take more time, more thinking, more effort to manage, we get paid less for caring for the elderly than we do a 22-year-old who comes in and simply needs a hammer toe or a bunion corrected. So in looking at the elderly patient and our role as podiatric physicians in caring with for these patients, we have the patients that have chronic illnesses with lower extremity manifestations with which we have to be familiar. We then have to deal with issues of palliative care, accommodative care, various end-of-life issues, and patient safety issues. We are dealing with, for the first time in history, the problems that come with aging and deterioration. Years ago, infectious disease was the major cause of mortality in the world, but now we're dealing with the effects of aging, diabetes-related pathology, the effects of peripheral arterial disease, the effects of obesity. So that, as Uncle Fester had said, this is what we're dealing with now, and literally deterioration of the body. We're also dealing with cognitive decline that occurs with aging. So it's like maintaining an old car and dealing with failing parts and aging parts, or as the comedian Buddy Hackett once said on the Johnny Carson show, after age 60, it's patch, patch, patch. And certainly we play a role in trying to maintain that old car, maintain quality of life for that patient, and prevent morbidity and mortality. And we have issues such as painful deformities and whether or not we should perform surgical procedures in the elderly patient, and if so, do we approach them in the same manner as we would a 25-year-old? Do we modify our techniques? What are the goals and objectives of doing surgeries in the elderly patient? And when we do these things, I think it's important to establish clear goals and objectives with the elderly patient and their family, and to document the concept of limited results, because at times we may modify our techniques or procedure selections not based on an X-ray, not based on a biomechanical examination, but rather based on the overall health of that patient. We also want to remember that not all elderly are the same, and there's tremendous variability from person to person, and therefore part of our decision making is certainly not based on a simple number, that is to say a simple chronologic age, but rather physiologic age. And we can have two patients who are the same age, the same sex, and yet have completely different physiologic states that will dictate how we approach those patients. And this has to be considered by us, certainly, and I think it's important to document those considerations. So the geriatric assessment involves tremendous thought regarding their comorbid conditions, in addition to vascular status, nutritional status. One of the major predictors of success is walking speed and stability, and the presence or absence of functional impairment. And I think it's important to evaluate this. I sometimes will ask students and residents about their experiences in various offices, and it is shocking, although frankly not surprising, that the majority of patients that students and residents see in private offices never get out of the podiatry chair. They are never asked to walk. They never receive any type of functional assessment or gait analysis. And this should be a major part of treating the geriatric patient. You certainly can play a major role in identifying such functional impairments and gait impairments. And if you're not prepared to treat these, you certainly are in a position to make appropriate referrals to improve quality of life, reduce the risks of falls, and so forth. We also need to assess or get at least a feeling for the cognitive abilities of the geriatric patients which we see. Can they care for themselves? Can they follow directions for wound care? Can they appropriately monitor their status following surgery? Are they apt to injure themselves? We need to look at support systems that are available. And with experience, I think most practitioners back away from just looking at that foot and determining what procedure needs to be done, but asking that patient, how many steps do you have at home? Who's available to assist you? Is there family available or friends available? Do you have a spouse or a significant other that's there to assist you? And we look at socioeconomic concerns. Is the patient able to purchase the medications and dressings? Are they able to arrange transportation to and from your office? Do they have the ability to comply with the requests from an economic standpoint? Similarly, social issues. I find a number of patients that I've treated over the years who live in neighborhoods such that they say, I cannot go out and walk. It's simply not safe. And these are all major concerns in caring for the elderly patient. In caring for the elderly patient, we also need to remember that there's more involved than just having them change their dressings, monitor their wounds, or care for their post-operative needs. Are they able to transfer? Are they able to go to the toilet? Can they groom? Can they feed? Are they able to dress themselves? Can they arrange transportation to your office? What happens if there's an urgent need? All of these things are important, and all of these things need to be considered in caring for the geriatric patient. So their ability to answer the phone, their ability to go and obtain whatever it is that you've asked them to obtain. Can they maintain their home? Who's going to prepare their food when they're tied up following some foot procedure or being treated for some type of a wound? All of these things become important in trying to achieve success in the older patient. And again, these are not things that we think about when we are treating the 18-year-old with an ingrown toenail or the 30-year-old with some plantar fasciitis, but these are important potential breakpoints between success and failure in treating the geriatric patient. And in looking at these things, I think it makes the difference, it defines the difference, if you will, between a true healthcare provider and someone who is limited in scope and limited in observation and really only capable of delivering a modicum of the actual care that the patient requires. There are several things one can do in terms of evaluating cognition. Certainly, we can gain a feeling for the patient just from casual conversation and observation. There are several tests that can be done that any podiatric physician can do. The mini cognition test is one such test, and that's the ability of the patient in front of you to just repeat 3 objects or items that you name. So you might say chicken, automobile, and clouds, and ask the patient, what is it that I just gave you in that list and see whether or not they're capable of repeating that. Another simple test is just hand the patient a piece of paper and have them draw the hands on a clock. For example, say draw 11:20, for example. And these mini cognition tests are helpful in evaluating patients. In treating the geriatric patient, we also want to look at their general health, their general disease burden. There are a number of ways to do this. We certainly want to take a look at the drugs that that patient is taking, the potential effects those drugs may have on their ability to function and to think. When looking at patients for surgery, we are certainly going to be assessing them for an ASA score. And there are various cumulative illness rating scales that are available. This is one such scale that's commonly utilized, the Charlson Index, whereby points are awarded for various disorders or the presence of various disorders, and for each decade over the age of 40, an additional point is added to their score. So we look at things such as history of myocardial infarction, the presence of congestive heart failure, peripheral vascular disease, COPD, the presence of dementia, liver disease, and so forth. And we get down to more serious issues such as the patient that we see with severe liver disorders, or the patient with metastatic disease, or the patients who have diagnosed AIDS. Certainly the patients with diabetes that have end-stage renal disease, the patient with leukemia or lymphoma. How many times now are we seeing patients with diagnosed cancer with metastatic disease? All these things play a role in our assessment of these patients. Another rating system is the cumulative illness rating system, and you award points 0 to 4, depending on whether there is systemic disease which is absent, mild, moderate, or severe. And I would suggest that the cumulative illness rating score would be a simple system, easily incorporated into the health records in our offices, and rather than having a simple drop-down, make pretend history and physical that never happened, we can in fact look at patients and assess them in terms of how much comorbid disease we're dealing with. Healing, of course, is dependent on nutrition, health maintenance, and homeostasis dependent on nutrition. And here again, there are simple things we can ask and assess. We could ask the patient whether there's been a 10-pound weight loss in 1 year, and if so, was that willful weight loss, or has there been a 10% weight loss in 1 year? We can look at some objective measures which aren't totally accurate but are helpful, things such as the serum albumin, or doing a mini nutritional evaluation. So generally you want to see where the patient's albumin and prealbumin are. It's been suggested by some that the total lymphocyte count might be appropriately used for the assessment of nutrition. Others have suggested looking at cholesterol, transferrin, or the C-reactive protein. And certainly when planning extensive surgical procedures on the older patient, or in dealing with complex wound healing issues, I think the area of nutrition is one that we tend to perhaps not work at hard as assessing. We also want to evaluate gait and stability and risk for falls. And there are certainly many ways to do this, and perhaps one of the most simple and recognized tests that one can do is the simple get up and go test. We could also look and note whether the patient is using a cane or a walker or some type of gait assistive device. And it's important to watch that elderly ambulate, arise from a chair, sit in a chair. And here again, if it's our impression that the patient is at some significant risk for falls, is unstable, we certainly can make appropriate referrals. It's important to look for neurologic gait patterns. Now, the get up and go test is easily done. The patient is asked to arise from the chair without using their arms for assistance. We observe them arise, they walk 10 feet, they turn around, they walk back to the chair and sit down. And we can look for the need to utilize the hands for assistance, their arms for assistance. If they do, that would suggest some weakness of the proximal leg musculature. We can look for instability and swaying or staggering, indicative of a potential neurologic problem. Watching the patient turn is important. If they take more than 3 steps in order to turn, here again, this may be suggestive of a neurologic deficit. We also can watch the patient walking and look for evidence of arthritic changes of the hip, knee, and back, and look for neurologic gait components. Now, in looking at the get up and go test, having the patient rise from the chair, walk 10 feet, turn around, and sit down, generally normal is considered less than 10 seconds. Most patients that can perform or complete this test in less than 20 seconds are generally independent. However, once we get over 20 seconds, the patients start to demonstrate variable degrees of immobility and functional decline, and certainly over 30 seconds, these patients, particularly if they require assistance, are at significant fall risk. So you want to observe the patient rise. You want to look for the need to utilize their arms for assistance. You want to look for swaying. You want to watch their arms swing. You want to look at the patient for any hemiparetic gait, any antalgic gait, any shuffling of the gait, broad base gait, whether there's any evidence of drop foot. And all of these things are important to assess. I think it's a major plus that you can bring to the table in assessment of the geriatric patient. And I think when that primary care doctor gets that note back showing that you did indeed assess the patient for their stability and their propensity toward falling, I think it goes a long way in telling that practitioner that this podiatric physician is indeed a competent doctor. Again, it's been surprising to some extent to hear students and residents tell me how often, how frequently they watch patients examined who have decisions made about their lower extremity function and health, and yet the patients are never observed to fall. The major geriatric syndromes that we have to be careful of are just that, history of falls, tendency toward falling, and dementia. It's important to ask patients if they've had a history of falls, how many falls they have had, because there are things that do occur with aging. And again, we certainly want to recall that dementia is important to assess because it's going to reflect on the patient's ability to be compliant or adherent, if you will, with our recommendations for wound care, postoperative care, or other recommendations that we make. In looking at the outcomes of podiatric interventions, the question is, what can we do to reduce the number of complications? What can we do to decrease the need for hospitalizations? What can we do to decrease readmission rates when treating wounds, vascular disease, when performing surgical procedures? What can we do to reduce the need for rehab and admissions to SNF units and institutional care? What can we do to reduce the actual cost of care? And when patients have been hospitalized with significant lower extremity pathology, what can we do to reduce post-discharge care in the first 6 months and 1 year? And looking at the outcome of our care, again, assessments of function and cognition, assessment of nutrition, overall disease burden with which we're dealing, looking at the patient's walking speed and stability and assessing them for geriatric syndromes, all are important markers to tell us or assist us in determining the appropriate health plan for our geriatric patients, because this is what we're now dealing with, patients that didn't expect to live this long. And the ultimate question is, in looking at the geriatric patient, a balance of risk factors versus outcome. And in looking at our clinical management, what we want is a good outcome and not have a poor outcome because we've been overwhelmed by unrecognized or untreated geriatric syndromes, the comorbid conditions, vascular disease, nutritional deficits, or the patients falling from general instability. Mickey Mantle perhaps said it best: "If I knew I was going to live this long, I'd have taken better care of myself." And we have others that have certainly made similar recommendations regarding how to live one's life and try to limit future geriatric complications. So in summary, it was back in 1969 through 1973 that my old professor, Dr. Arthur Helfand, told us all the future of this profession is going to be geriatrics and diabetes. And I remember looking at him and thinking, what does this guy know? And a salute and a tip of the hat to Dr. Helfand, because what do we see in our country today? Increasing diabetes, increasing geriatric population, and as podiatric physicians, I think we have an obligation toward better education in this area in order to make appropriate diagnoses and treatments of these patients. Thank you for attending this session of the Center of Podiatric Education.